are cracking open a file that I think a lot of us think we know, but the reality is vastly more complicated and honestly a bit more terrifying than the common perception. We're talking about psoriasis. And I have to admit, before I read through our source material for today, which is chapter 17, from a massive comprehensive medical text on dermatologic disorders, I was firmly in the camp of it's just bad, dry skin, right?
And that is the single most common misconception we encounter. You see a commercial, maybe someone looks a bit uncomfortable in a tank top, and you categorize it as, a cosmetic annoyance.
Right.
But if you take one thing away from this deep dive today, it should be that psoriasis is not skin deep. It is a chronic, systemic, inflammatory disease. It is a fundamental glitch in the body's security system.
Right. It's not just a rash. It's a civil war inside the body.
Yeah.
And our mission today is to decode the medical jargon in this text. We're going to trace the path from the microscopic genetic battles happening in the immune system to the symptoms we can actually see. And then we're going to map out what is frankly a staggering arsenal of treatments available today. We are going to go from oatmeal baths in your bathtub to what look like genetically engineered biological missiles.
It really is a journey from the kitchen cabinet to the cutting edge of biotechnology. We have come a long way from just putting tar on the skin, though. As we'll see, that is actually still part of the conversation.
It's all on the table.
But to understand the treatments, we have to respect the beast we are dealing with.
So let's define the beast. The text gives us a very specific definition. It calls it a chronic inflammatory disease characterized by recurrent exacerbations and remissions.
Let's break that down because those words carry a lot of weight. Chronic means it is not going away. There is no cure, currently only management.
It's for life.
It's for life. Exacerbations are the flare-ups, the times when the war heats up and the symptoms get worse. And remissions are the ceasefires, the periods of calm. It is a cyclical battle that a patient fights for their entire life.
And visually. The text describes the result as thickened erythematous and scaling plaques. Erythematous is just a $10 word for red, right?
For red, yeah. Specifically, it's redness caused by vasodilation, increased blood flow to the area. But the plaque part is key. This isn't just a flat rash like a heat rash. It is raised, it has texture and height.
Oh, wow.
It is a physical buildup of biological material that just shouldn't be there.
Which brings us to the why. This is the part of the chapter that really blew my mind. The pathophysiology. The text doesn't blame the skin cells initially. It lays the blame squarely on the T cells.
It does. Psoriasis is fundamentally a T-cell-mediated disease. Now, for context, T cells are usually the heroes of your immune system. They are the special forces designed to hunt down foreign invaders like bacteria or viruses. They are the good guys.
Right.
But in psoriasis, you have this T-cell mistake. The security system gets bad intelligence.
Okay, let's unpack this mistake. The text mentions that for this inflammation to kick off, there are specifically two signals required. It felt a bit like watching a movie where two people have to turn the keys simultaneously to launch a nuclear missile.
That is a fantastic analogy, and it's exactly how the immune system is designed for safety. It's called the two-signal model. You can't just have a T cell firing off because it thinks it saw something.
That would be chaos.
That would be dangerous. You'd be inflamed all the time. So signal one is the interaction of the T-cell receptor with an antigen. That's target identification. It says, I see something foreign.
But that's not enough to pull the trigger.
Correct. If you only have signal one, the T-cell actually goes into a state of unresponsiveness. It powers down. You need signal two, which is co-stimulation. This happens through specific surface proteins interacting between cells. It's the second key turning.
So in psoriasis, both keys turn when they shouldn't.
Exactly. Both keys turn. And once that happens, the T-cell is activated. And an activated T-cell doesn't just sit in the lymph nodes or the bloodstream where they usually hang out. They mobilize.
So they migrate.
They migrate right into the skin. And this is where the trouble starts. Once they are in the skin, they release the chemical storm.
The text lists a whole alphabet soup of chemicals here.
These are cytokines. Think of them as the battle cries or the radio orders. The text lists the key players. Interferon gamma, interleukin-2, or IL-2.
TNF-alpha, I saw that one a lot.
TNF-alpha is a big one, and IL-8. These chemicals scream at the local skin cells, the keratinocytes, telling them to panic.
And the consequence of that panic is proliferation, right?
Yeah.
The skin just starts growing.
Yes. T cell production and activation results in keratinocyte proliferation. The skin cells start growing and dividing way, way too fast.
I looked up the numbers on this to visualize it. Normal skin cells take about a month to mature and shed off your body, right?
Roughly 28 days is the standard turnover cycle for a healthy epidermis.
Okay, so a month. In psoriasis, the text says this cycle is compressed into, what, days?
3 to 4 days.
3 days.
Imagine a factory line suddenly speeding up by 800%. The product, the skin cells, doesn't have time to mature or shed properly. They just pile up on top of each other because they can't leave the surface fast enough.
And that pileup is the plaque.
That pileup is the plaque, that silver scale you see. That's thousands of immature skin cells that have nowhere to go.
And we can't talk about this mechanism without mentioning the genetic lottery. The source material mentions a specific association with HLA-CW6.
HLA-CW6, yes. HLA stands for human leukocyte antigen. It's basically the barcode on your cells that tells your immune system, this is me.
Okay.
Studies show a significant genetic component here. If you carry the HLA-CW6 marker or have certain associations with TNF-alpha and IL-3 variants, your risk is much higher. It is not a guarantee you'll get it.
But it loads the gun.
It loads the gun, exactly. The environment stress, an injury, an infection that pulls the trigger.
So we've got the microscopic view, the T cells going rogue, the chemical screaming, and a traffic jam of skin cells. Now let's zoom out. What does this look like in the real world? The text focuses heavily on plaque psoriasis.
Right, psoriasis vulgaris. This accounts for about 90% of all psoriasis cases. If you see someone with psoriasis, statistically, this is what they have.
And the description is pretty specific. Red-violet color, at least 0.5 centimeters in diameter.
And well-demarcated boundaries. That is crucial for diagnosis. It means the lesion has a sharp edge. It doesn't just fade gradually into normal skin like, say, eczema might.
I see.
It is a distinct territory of inflammation. And the hallmark, they are covered with silver flaking scales.
Location-wise, are we talking specific spots?
It can be anywhere, but there are predisposed areas. Knees and elbows are the classics. The scalp is another very common one. But it can be generalized, covering a wide body surface area or BSA.
The text also emphasizes the sensation. It's not just that it looks red, it itches.
Pruritus, that's the medical term for itch. And it's not a mild tickle. The text notes it can be severe, leading to scratching and excoriations, which are wounds caused by scratching.
And that creates a vicious cycle.
It does.
The Koebner phenomena, right?
Exactly. Trauma to the skin triggers more lesions. So you itch, you scratch, you damage the skin, and the immune system responds by creating more plaque right on that spot. It is a trap.
And the social impact. The text didn't shy away from that.
No, and it shouldn't. It explicitly mentions the condition can be physically debilitating or socially isolating. Imagine having visible shedding plaques on your arms or your face.
Yeah.
Patients often wear long sleeves in summer. They avoid swimming pools. The psychological burden is a huge part of the clinical picture.
Now, here's where it gets really interesting, or scary, depending on how you look at it. It's not just the skin. The text connects skin lesions to joint inflammation. Psoriatic arthritis.
This is the link many people miss. Psoriasis is a systemic inflammatory disease. That same cytokine storm, that TNF-alpha, doesn't just circulate in the skin, it can attack the synovium, which is the lining of the joints.
The text highlights specific targets. The discal interphalangeal joints.
Those are the joints closest to your fingertips. If you see a patient with psoriasis who also has pitting or crumbling fingernails.
Oh, the nails are a sign.
The adjacent nails, yes. If you see that, you need to be very worried about their joints. But it can also hit the knees, elbows, wrists, and ankles. If left untreated, it can be destructive and permanently fuse joints.
So if you have the skin condition, you need to be watching your joints. How do doctors actually diagnose this? I assume they'd just take a piece of skin and look at it under a microscope.
You would think so, but here's a surprising fact from the text. Skin biopsies are not typically diagnostic of psoriasis.
Really? That seems completely counterintuitive.
It does, but under a microscope, a lot of inflammatory conditions look somewhat similar. You see T cells, you see thickened skin. The diagnosis is based primarily on the physical exam.
Just by looking at it?
Just by looking at it. They look for those characteristic lesions we discussed. The silver scales, the well-demarcated red plaques, the location on knees and elbows. The visual pattern is usually more reliable than the biopsy.
And how do they measure how bad it is? I saw terms like PASI and BSA.
Right. BSA is body surface area, literally what percentage of your skin is covered. One handprint is roughly 1%.
Okay.
TSI stands for Psoriasis Area and Severity Index. It's a complex score calculation involving redness, thickness, and scaling. But interestingly, the texts note a 2011 European classification that simplifies things. They just split it into mild or moderate to severe.
Keep it simple. I like that. Okay, so we know what it is, we know why it happens, and we know how to spot it. Now comes the big part. How do we fix it, or at least manage it?
The treatment goals are multifaceted. It's not just make the red go away. It's minimize lesions, stop the itch, reduce the frequency of those flare-ups, and treat comorbidities like the arthritis.
And improve quality of life.
And importantly, improve quality of life, yes.
And the text starts with something surprising. Before we even get to the drugs, it talks about lifestyle, and specifically, stress.
This brings us back to that immune system connection. Stress releases cortisol. Cortisol and the immune system are tightly linked. The text states that stress reduction, specifically mentioning techniques like guided imagery, can actually improve the extent of the disease.
So it's not just in your head, it's a tangible link between mind and skin.
A very real physiological link.
That is fascinating. And then there's the basic care, oatmeal baths. I feel like my grandmother would suggest that, but here it is in a medical text.
Grandmothers often know best. Colloidal oatmeal is a powerful antipyretic. If you itch less, you scratch less. If you scratch less, you have fewer lesions. It can reduce the need for systemic antipyretic drugs.
Makes sense.
They also emphasize tepid water and lipid-free cleansers. Harsh soaps are the enemy here because they strip the skin of moisture.
And moisturizers.
Essential. Absolutely essential. They control scaling and reduce shedding. Think of the plaque as a dry, brittle wall. Moisturizer adds mortar back in, keeping it intact and less likely to flake off.
One more lifestyle thing, son. We're going to talk about light therapy later, but the text explicitly says you still need sunscreen.
SPF 30 or higher. Just because light can be a treatment doesn't mean you want uncontrolled sunburn. Sunburn is skin damage, and as we said, skin damage can trigger a flare-up via the Koebner phenomenon.
It's a delicate balance.
A very delicate balance.
Okay, let's open the medicine cabinet, segment 2. Topical therapies.
Yeah.
These are the first line of defense. And the big dog here seems to be corticosteroids.
Corticosteroids are the workhorse. They
Yeah.
do it all. They are anti-inflammatory, anti-proliferative, which means slowing down that cell growth,
Right.
and vasoconstrictive, so they constrict blood vessels to reduce redness.
But not all steroids are created equal. The text describes a potency ladder.
Yes, there are 7 classes. Class 1 is the super potent category. We're talking drugs like clobetasol propionate. These are the heavy hitters.
And class 7.
Class 7 is the least potent, like your standard hydrocortisone you might buy over the counter.
So why not just use class 1 for everything and knock it out?
Because with great power comes great responsibility and significant side effects. The text lays out strict rules of engagement. You use lower potency for infants or for thin skin areas like the face or skin folds.
Okay.
You reserve class 1 for thick plaques, palms, or soles areas where the skin is tough. And even then, you limit class 1 use to just 2 to 4 weeks.
Because if you use it too long.
You get adverse effects. Skin atrophy, which is thinning of the skin. It can become paper thin and fragile. You can get acne, stretch marks, or striae.
Yikes.
And if you use enough of super potent steroid, it can actually absorb into your blood and cause systemic issues like Cushing's syndrome or cataracts. It's not something to play around with.
So steroids are option A. What is option B? The text mentions something called calcipotriene.
Calcipotriene is a vitamin D3 analog. It's clever. It binds to vitamin D receptors and inhibits keratinocyte proliferation. It just tells the skin cells to stop multiplying so fast.
Is it as good as steroids?
For mild psoriasis, the text says it's more effective than anthralin, which we'll get to, and comparable to mid-strength steroids. The upside is you don't have the skin thinning risk of steroids.
But there's a downside.
There's always a downside. It can cause burning or peeling. And a note for our listeners, it's pregnancy category C, meaning risk cannot be ruled out.
Then we have tazarotene. Sounds like a retinoid.
It is. It's a topical retinoid. It normalizes a differentiation of cells, basically teaching the skin cells how to grow up properly.
Right.
But it comes with a burn. There is a high incidence of irritation.
The text had some tips for that, didn't it?
Yes. Use the cream instead of the gel, alternate days, or do short contact treatment where you leave it on for 30 to 60 minutes and then wash it off.
But the biggest, most critical warning here.
Pregnancy category X.
Category X means absolutely do not use if pregnant.
Correct. It can cause birth defects. Do not use it if you are pregnant or planning to become pregnant. It's a very serious warning.
Okay, there were 2 more topicals mentioned, but they were described as the old guard, anthralin and coal tar.
Anthralin has a direct anti-proliferative effect. The preferred way to use it is scat short contact anthralin therapy. You put it on the thick plaques for 2 hours, then wipe it off.
Sounds messy.
It is, and it irritates normal skin, so you have to protect the surrounding area with zinc oxide paste. It's very messy.
And coal tar.
It's exactly what it sounds like. It's keratolytic, it breaks down scales, but it smells like a road crew paving a street, it stains your clothes, and patients just don't like using it. Compliance is terrible. It's rarely used now, but it's part of the history.
Moving on to segment 3. Turning on the lights. Phototherapy. This sounds sci-fi, but it's a standard treatment.
It is. The concept is using non-ionizing electromagnetic radiation light as a drug. The most common form is UVB, specifically narrowband UVB or NB-UVB.
And they sometimes combine this with those old guard topicals we just mentioned.
Right, they have names for them. The Guruckerman regimen is UVB plus coal tar. The Iniarm regimen is UVB plus anthralin. It boosts the efficacy.
How does that work?
It turns out if you strip the scale with tar first, the light penetrates deeper and is more effective.
Then there's PUVA.
PUVA.
PUVA stands for Psoralen plus UVA. Psoralen is an oral drug you take. It makes your skin incredibly sensitive to light. Then they expose you to UVA light.
That sounds risky.
It has risks. Immediate risks are things you'd expect: sunburn, itch, and blistering. But the specific PUVA risks are interesting. Nausea is common from the drug. Taking it with milk or food helps.
Okay.
But here's a big one. You need eye protection for 24 hours after taking the pill.
24 hours, even indoors.
Even indoors if there are windows.
Yeah.
The drug distributes to the lens of the eye. If sunlight hits your eyes while the drug is active in your system, you have very high cataract risk. You can permanently damage your vision.
And long-term, PUVA is associated with photoaging, premature aging of the skin, and carcinogenesis, a real cancer risk.
It really is a balance of risk and reward.
Yeah.
Now let's say the topicals fail. The light therapy isn't enough. We are moving to segment 4, bringing out the heavy artillery, systemic therapies. These are pills, mostly.
This is for moderate to severe cases, yeah. And the first one the text breaks down is acitretin. It's an oral retinoid.
We saw topical retinoids earlier. This is the pill version.
Exactly. It's usually combined with a light or calcipotriene because it's not super effective alone. But the side effects, they are significant. Retinoid dermatitis, dry eyes, dry lips, brittle nails, even skeletal abnormalities.
And the pregnancy warning.
It is the most severe warning in the entire text. It is teratogenic category X. But unlike the topical where you stop using it and it clears your system relatively quickly, acitretin is lipophilic. It sticks around in your fat tissue. Women must use contraception during therapy and for 3 years after stopping the drug.
Wait, 3 years?
3 years.
That is a massive commitment. If a woman is 28, she has to wait until she's 31 or 32 to even think about having a child.
Precisely. It is a huge consideration for any woman of childbearing age. It effectively puts their family planning on pause for years.
Next on the list is cyclosporine.
Cyclosporine is the rescue therapy. It works fast. It induces remission rapidly. It's great for nail psoriasis or something called erythrodermic psoriasis, which is when the whole body is red. It's the firefighter you call when the house is blazing.
There's a catch.
There's always a catch. The crash. Relapse is very common, usually within 4 months after stopping. So you have to taper it slowly.
And while you're on it?
While you're on it, it's tough on the kidneys, nephrotoxicity. It also causes hypertension, so high blood pressure. And the risk of skin cancer increases the longer you are on it. So it's a bridge, not a permanent home.
So good for a quick fix, bad for the long haul. What about methotrexate? I've heard of this one used for other things too.
Methotrexate is the gold standard for comparison. It's more effective than acitretin and similar in efficacy to cyclosporine. It's dosed weekly. It inhibits DNA synthesis, stopping those cells from dividing so fast.
What are the risks here?
Liver toxicity and lung toxicity. It can be hard on the liver, so regular blood tests are mandatory. It also causes nausea and anemia because it messes with folate levels.
So how do you manage that?
To combat that, patients take folic acid supplements. It helps reduce those side effects.
Unpregnant.
Contraindicated. It is an abortifacient. It induces abortion and is teratogenic. Absolutely category X.
It seems like all the heavy artillery comes with heavy baggage. But now we enter the modern era. Segment 5, the biological revolution. BRMs.
Biologic response modifiers. These change the game. They are usually second line because they're expensive. We're talking tens of thousands of dollars a year.
Wow.
But they are powerful. They don't just suppress the whole immune system like methotrexate. They target specific parts of the immune pathway we talked about in the intro. They are snipers, not carpet bombs.
Let's talk about the TNF-alpha inhibitors.
TNF-alpha was one of those cytokines in the chemical storm. These drugs block it. You have adalimumab, known as Humira. It's a monoclonal antibody. You inject it every other week. It offers quick control.
Then there is etanercept or Enbrel.
Enbrel is a fusion protein. The text notes it is fully humanized, which means there is less risk of your body reacting to the drug itself as a foreign substance. You take it twice weekly initially.
And infliximab or Remicade.
That's the IV infusion. You go to a clinic, get an IV every 8 weeks. It's a chimeric antibody part mouse, part human protein.
What are the risks with these, since they block a part of the immune system?
Infections, that's the big one. TB or tuberculosis is a major concern.
Why TB specifically?
TNF-alpha is actually used by the body to keep latent TB asleep inside granulomas. If you block it, you can wake the TB up. Before starting any of these drugs, you have to be tested for latent TB. Also, upper respiratory infections are very common.
There are other targets too, right? Not just TNF-alpha.
Yes. There is alificept, which is called Amivive. It targets the T cells directly, binding to a protein called CD2. It actually reduces your lymphocyte count.
Yep.
And then there is ustekinumab, or Stelara.
The Stelara targets interleukins.
IL-12 and IL-23. Remember those from the chemical storm. This drug blocks them. Dosing is interesting. It's based on weight. If you are under 100 kilograms, so about 220 pounds, you get 45 milligrams. Over 100 kilograms, you get 90 milligrams.
And it's only every 12 weeks.
Every 12 weeks, that convenience is a big selling point for patients.
That's a lot less frequent than the others. Is there a catch?
A rare one. Reversible posterior leukoencephalopathy syndrome, or RPLS. It's a brain condition involving swelling. Very, very rare, but noted in the text as a risk.
Wow. Okay, so we have topicals, light, pills, and biologics. Segment 6 is about strategy. How do doctors put this puzzle together? The text talks about combination therapy.
Why use one weapon when two work better? Combining therapies enhances efficacy and can minimize toxicity because you might be able to use lower doses of each drug.
Can you give us an example of a good combo?
A classic topical combo is a steroid plus a vitamin D3 analog. There is a product called Taclonex that combines them. The vitamin D helps with the proliferation, the steroid helps with inflammation, and the combo actually causes less irritation than using them separately.
What about combining systemics and light?
This is where you have to be really careful. Retinoids plus phototherapy is very effective because the retinoids thin the plaque, allowing the light to penetrate deeper.
Right.
But and this is but retinoids thin the skin and sensitize it. If you use the normal dose of light, you burn the patient. You must lower the light dose.
That makes sense. The text also mentions some alternative options that are off-label.
Yes, for when standard things fail. Mycophenolate mofetil is one. It inhibits DNA and RNA synthesis. Not FDA approved for psoriasis, but it's used. It has GI toxicity and a lymphoma risk.
Still serious stuff.
Another is hydroxyurea. It inhibits cell synthesis in the S phase, but it suppresses bone marrow. These are truly last resorts.
Scary stuff. So how do we know if any of this is working? Measuring success.
Patience is key. The text explicitly says sustained benefit takes 2 to 8 weeks. You might see a quick change with a strong steroid, but real healing takes time.
And success looks like.
Reduced erythema, so less red, reduced scaling. And flatter plaques. They use the PSI score we mentioned, but also quality of life assessments. Because if your skin looks better but you are miserable from side effects, that is not a success.
That's a great point.
And honestly, the goal is often control, not cure. Normalization of the skin, getting back to a point where the disease isn't running your life.
So we've unpacked a lot today. Let's head to the outro and wrap this up.
Psoriasis is clearly a multi-front war. It's genetic, you have the HLA markers, it's immune, the T cells and cytokines are the soldiers, and it's environmental stress, injury, weather can all trigger a battle.
And the evolution of treatment is remarkable. We've moved from essentially dipping people in coal tar, which sounds medieval, to using targeted genetic missiles, like the biologics that pick off specific proteins in the blood.
It is a triumph of understanding pathophysiology. Because we figured out exactly which chemicals were causing the storm, we could build drugs to block just those chemicals. It's incredibly precise.
But it's not without cost, financial, and physical risks.
Absolutely. Every treatment from the potency ladder of steroids to the immunosuppression of biologics carries weight. It's a constant calculation of risk versus benefit for the patient and doctor.
Here's a final provocative thought for our listeners to mull over. We talked about how the immune system is designed to protect us. It's our body's security team. But in psoriasis, it turns into the aggressor.
And consider just how fragile that balance is. The text detailed that activation requires just two signals: interaction with an antigen and co-stimulation. Just two keys turn and the body transforms into a landscape of inflammation. It really highlights that health isn't just the absence of disease. It's a constant, delicate, active balance maintained by millions of cells every second. When just one pathway misfires, you see how powerful and destructive our own biology can be.
That is something to think about the next time you look at your skin. It's doing a lot more work than just holding you together. Thanks for listening to this deep dive into psoriasis. We hope you learned something new.
Stay curious and take care of your skin. See you next time.